Welcome everyone to another episode of Rehab Now with consultant physiatrist and rehabilitation medical doctor, Dr. Paula Dawson. I am your host, Alicia Taylor. Hello, Doc.
Hey, Alicia, how are you?
I am great.
Hi, listeners.
Welcome, everybody. Rehab Now is brought to you by the Rehabilitation Institute of the Caribbean, Winchester MRI, Immune Active Denk, and Almighty Studios. Now, this week, we are going to inject some information about pain relief by talking about the types of injection used to relieve pain. I don't know how that makes sense. You're going to inject me to relieve pain, Doc?
That's kind of an oxymoron.
It really is.
It's oxymoron?
Yeah, man.
Yes.
Paradoxical bad.
Paradoxical, another English word. Me use medical terms, you use the big language terms.
I love that.
Onomatopoeia?
Yeah, man. Cause we're bright. Is we say big terms. Is we say recondite expressions.
Ooh.
Yeah, man.
Whoa,
know what I'm saying?
whoa.
Okay, great. So remember, you guys can check out our social media pages for information about injections for pain relief.
Yes.
On Instagram, we're Rehab Institute Caribbean, Dr. Paula Dawson, Alicia Taylor Music, and on Facebook, Rehabilitation Institute of the Caribbean. Website, rehabcaribbean.com. Doc,
Yes, ma'am.
talk to us about injections for musculoskeletal pain.
What's an injection? An injection is where we use a hypodermic needle. It's a little needle.
You said little?
It can be little. Most times.
Because I don't ever see a little needle.
What you talking
I've
about?
never seen a small needle in my life, is what I'm saying. Doctors, for me, always just take up the big pointed one, ploop, and you see the something squirt out.
They're usually pointed.
It's traumatizing.
Okay. All right. So it's actually a small needle. They're small, because, all right, so we
So
use
is the bottle big?
the syringe. Ah, very good. You're actually very, very smart. It's a syringe. It's a bottle, the container that holds a medicine that looks big, but the needles are usually small. But essentially what we do, an injection is something that we put in the muscle to help to relieve pain. Okay. And not only the muscle, it can be in a joint, it can be in the spine. And so there are different types of injections. So let's talk about injection from outside in.
Okay,
right?
outside in, great.
Outside in, meaning it can be just in the muscle called an intramuscular injection. So the intramuscular injection is an injection into the muscle. It can be in the joint. Intra-articular injection, which is into the joint itself. It can be periarticular or bursa, like in the shoulder. We inject for rotator cuff. We call that subacromial bursa injection. And we're going down. It could be in the spine, where you can go at the side, called transforaminal, under X-ray guidance, or cord. Or I'm showing off now. All right, let me reel it back. So it can be either spine injection, or it can be in tendon, peritendinous.
Quick question before you go any further. So the further we go inside, the more pain we feel with the
Not
injections?
at all.
Okay.
Not at all. Right. So, all right, so let's start from the top. One of the most common injection you'll get. Oh, and I forget the intramuscular injection that you get, which is, for example, Voltaren, or when...
Oh, I know that one.
Yeah, or it can be diclofenac, because Voltaren is a name brand. And they're not our sponsors. You can come on board next time if you want us to call you some more. Right? But we have... Denk Pharma has diclofenac injections.
Okay.
So we can use Denk Pharma type injection. Right. And so we can actually inject into the muscle. So, sometimes when you have a whole heap of pain, or you drop her in an accident, you go emergency room and inject in your buttocks, with an anti-inflammatory, that is for pain. Right? But they can also give you a muscle relaxant as well to relax the muscle. And so that's a simple intramuscular injection. It's not necessarily at the site of the pain, but it's to enter the body. So you can have pain in your knee or pain in your neck, and they give you a butt injection, because it's a nice big muscle, and it absorbs, and it has a lot of blood flow, and it takes the medication and carry it around the body.
Oh.
Right. Sometimes they can inject you in the shoulder, but because you use your arm, they tend not to want to do that, right? So the next injection we do injection in the muscle into trigger points. Now, we're going to talk about myofascial pain, or myofascial pain is a type of pain that is in the muscle where the muscles are in knots. And we can actually go in and inject that. It depends on what you use,
Inject the nuts.
Inject the nuts. But let's not talk about that, because, we're going to talk about today intra-articular and epidural injection.
Epidural.
Right. And so I have a lot of patients with knee pain right?
Okay.
And so you have knee pain, whether the knee pain is due to arthritis or Alicia does not like
Hate
arthritis.
that man.
And arthritis, guys, for those who don't know, arthritis is usually at the joint.
Yeah.
So the joint has two bones that are articulating, that are moving, and the joint is covered by cartilage. Arthritis is where, one, the joint space decreases. That's one, so the bones get closer together.
Yeah.
The cartilage, which is the cushiony part, wears down,
And so the bones are
rubbing together, and then eventually it can get bone spurs.
Gosh.
So that's basically, and so that can occur anywhere. It can occur in the fingers. You can have it in the fingers.
Can occur in your ears.
It can occur in your ears. It certainly can. And so when you have that, you can get a lot of knee pain. And so I'm sure you've heard some people say they get a cortisone shot.
Yeah, I've heard that.
In the knee.
I've heard that.
Right. And so cortisone is a type of steroid. It's a good steroid, right? It's called endogenous steroid. So you have the so-called other anabolic steroid, which is what you use to build up your body. Like if you want to get big and tough and your voice change. Right. So that's anabolic steroid. But that's not the steroid we're talking about. We're talking about glucocorticoid steroid. Glucocorticoid steroid.
Okay.
And this is the steroid that is used to help inflammation in the body. And so, for example, if someone is bitten by a bee, and they're allergic to bee sting and they can't breathe, they give you steroid to open up to breathe. Or if you're asthmatic and you can't breathe, the lungs closing in, they give you that kind of steroid. So that's a good steroid.
Okay, good.
The thing with steroids, though, you can't use it for too long because it comes with a lot of side effects. So you shouldn't be afraid of steroid, but you should be cautious with long-term use of steroid.
Okay.
Right? And so the medications that we use, like the anti-inflammatory, they're called non-steroidal anti-inflammatory, like the ibuprofen and the naproxens. Those are the medications. Those are non-steroidal. And so you inject the knee joint to help to quiet down inflammation. So sometimes patients may have arthritis and you have a lot of effusion, which is fluid in the knee, water knee. You ever hear me talk about water knee?
Yes,
Right.
I've heard that.
And so people will have water knee or fluid in the knee effusion, and we go in and we pull out the fluid and we throw it away because the more fluid you have in there, it can make the joint tight and painful. They actually get a relief once I've had patients where you take out like 15 mils, 20 mils, and when you finish, they're like, oh, the pain is so fluid.
Oh, wow.
Right, it's just because the fluid builds up. And of course, you discard it, but you have to look at it. You have to make sure it's straw color. It looks like a pale yellow, and it's not cloudy, and it's not too bloody. Once it's like that, it's just plain effusion, right?
Okay.
Because you can have infection in the joint. And so if you have joint infection, it looks more murky and you may have a little pus and all of that stuff.
Like a lot of stuff.
Right, So, but it's just to keep it clean now. The really thing, because I know a lot of people like, what? That's a lot of information. You can get that in the knee. We also inject, for example, we inject the shoulder. People get rotator cuff injury, which is, especially women. Have you ever reach back to get your handbag?
Time and time again. It's what I do.
And hurt your shoulder.
Yeah, man. All the time. Just go, whoa,
rotator
back.
cuff. Very famous, with women that are reaching back, or your children in the back and say, "Yeah, yourself."
Yes, it's true.
Right, and you go, oh, you hurt your shoulder. So you get rotator cuff injury. And so we can do what we call subacromial bursa injection. So just under where the tendons glide, there's a bursa. And a bursa is really just a sac that allows the tendons to glide over without friction. And so we inject that with steroids and lidocaine.
And these are trigger point injections?
No, trigger point is in the muscle.
Okay.
No, we're talking about around the joint or around the tendon, peritendinous. So anywhere you have pain, most places that you have pain, we can inject around the area if the pain is secondary to inflammation. You understand? So arthritis can cause, your favorite thing can cause inflammation, right? There are so moving down the body. So we're starting from the knee, but we reach to the shoulder. You can also have carpal tunnel syndrome. And carpal tunnel syndrome is where... So the carpal tunnel has 10 structures. 9 tendons, 1 nerve, the median nerve going through.
Okay.
And so the tendons, these are the ones that make you do that. You have a set that make you do this, and you have one set that make you do that. You can do that. Bend the joint at the knuckles, bend at the middle knuckles, and bend at the far knuckles. So those are different tendons. So there are 10 of them. And 1 nerve, but that poor little nerve in the canal sometimes gets squeezed. And then you get pain.
Yeah.
And so you can actually go in and inject the carpal tunnel to relieve it.
Man.
You can get arthritis in your thumb. the MCP joint, metacarpal phalangeal joint. So we can inject that with steroids.
I don't know where you
well.
can't get arthritis. So
I know, right? So those are the articular injection, carpal tunnel. The orthopedic surgeons are very good at doing it, right? You can also get what we call a trigger finger. So a trigger finger. So you ever try? Well, some people with a trigger finger, they bend their fist, and then one of the fingers just can't go out. It's stuck, and then you have to click it open, and it's called a trigger finger. They call it, and it can be very painful. And what's a trigger finger? It's the tendon. It gets a little swollen, and it gets stuck through what we call a pulley system that's in the fingers. And sometimes we can go in and inject that as well. So you can inject the trigger finger, you can inject carpal tunnel, you can inject the MCP joint by your thumb, the base of your thumb. People can get arthritis right at the base of the thumb.
Okay, so how do we get to the stage of injection? I just go in and say, give me an injection because I'm feeling pain?
And you know, I like that question because here comes the algorithm. Love it. Never forget the algorithm. You always have to start low and go slow. So people will come in with pain in the hand, pain wherever. And the first thing you want to do is rehab. So I have a big category. In my rehab category is physical therapy, if you need it, home exercise, lifestyle. What does that mean? You may need physical therapy to quiet the inflammation. You may need ultrasound or different modalities to quiet the inflammation. The next thing you may need is a home exercise program. We're going to give you something to do so you can ensure that you recover.
Right.
But one of the most important thing is to look at your lifestyle. So if you're someone who's always on the phone, WhatsApping or whatever it is that you do, and we're doing therapy twice a week, and you're not
continuing,
changing, so we have to look at your lifestyle. You know, some people will be. It depends on what they do. They may drive and they may hold their leg in a particular position, and it may cause pain in the knee. And so we have to change your lifestyle. If you are someone who uses a computer and you get carpal tunnel, you know, we're going to do an episode on carpal tunnel. We want to raise your wrist up. You know, so you're not cocking up your wrists. Can you say that on here?
I think you already did. You know, okay.
You extend the wrist up in the air so that can cause a lot of pain. And so to answer your question, you go through that rehab first, then you do medication, which is anti-inflammatory. Then number 3 will come the injection. And if that fails, then you may need surgery. I love it.
I know the algorithm. Do you know the algorithm?
For musculoskeletal care?
Well, we're going to take a break. When we come back, we're going to talk about a whole lot of things that we're not touch yet.
Yes.
For the bone and for the joints.
That's correct.
So stay with us.
Yes.
Welcome back to Rehab Now. If you're just joining us, we're talking about injections. Doc just brought us through the algorithm.
That's right.
Yeah, man. Yeah.
Yeah.
And so we were talking about rehab, home exercise, lifestyle. I particularly like lifestyle because a lot of times we're doing things that we don't know is really affecting us badly. And so we go through the treatments and everything and then we go back to doing the same things.
Yeah.
And so the lifestyle change is very important.
Very important.
Yeah.
Yeah.
But let's continue.
Right. So where you want us to continue? So we spoke about intramuscular steroid. There are other things you can inject in the muscle. You can inject PRP, platelet-rich plasma. I think the last season we spoke about PRP. And what is PRP? Platelet-rich plasma. This is kind of relatively new medicine over the last 10 to 15 years. So it really, what we do is we take your blood, your own blood. We take your blood. Somebody comes and they pull your blood. We put it in a centrifuge, a machine, and we spin the blood down.
Is this where you're like making blood cells or new blood?
Exactly. Separating the blood components. And so you'll have the white cell at one level, the red cell at one level, and the platelets at one level, and then the fluid, the serum in which the cells flow. So we take off the layer of the platelets and we actually inject it wherever the problem is. So you have PRP, platelet-rich plasma injection in the muscle for athletes so they can heal quicker.
That's mind-blowing.
I know. We can do it in your knee. We can do it we sometimes intradiscal in the disc in the lower back. So PRP is another method of treatment that you can do for pain. And so we do it in the joint, we do it in the muscles. In the joint also, for example, we do in the knee joint, and after a while, or we even inject the hip, but the hip has to be injected under X-ray guidance because it's a deep joint. Right. But say we do the steroid injection in the knee and it doesn't work. There's something else we can inject in the knee, which is a lubricating agent called hyaluronic acid. HA for short. Just say HA for short. HA, hyaluronic acid. And originally, hyaluronic acid came from the chicken comb. You know the comb over the chicken head?
No,
because it came from the chicken comb. So it's actually lubricating
the actual
chicken comb. Now they make it in a lab. It's now synthetic. But prior to this, it actually is lubricating. So it's a viscous kind of like a lubrication, like you grease your engine or you grease the bearings.
I know we compare a lot of things to chicken, and in rehab now, but I really honestly did not know
that the hyaluronic acid came from the chicken comb. But we tend not to use that as much, although there's still one on the market that uses that because it's natural. But you have people who are allergic to eggs; they may have allergic reaction to that.
Yeah, okay.
And so they have the synthetic ones now they're actually more expensive. But the thing with hyaluronic acid, it helps to lubricate, for want of a better description, and it also stimulates some cells called the synovial cells. Those are the cells in the lining the knee, for example, or the joint, to produce its own fluid. Because if the knee dry out, it go
a problem. It's problem.
You're gonna hear a lot of.
You're gonna knock for true. You know what I'm saying?
And not valgus. Not genu valgus.
Not genu valgus.
Right. So genu valgus is the term for knock knee. And what's bow leg?
Genuvara.
Genuvaro.
I was right.
Very good.
I was hoping I didn't remember the bow leg people.
Yes, you did. But anyway, so we can use hyaluronic acid in the knee. We can also use stem cell. And so stem cells are pluripotential cells. Pluri just means plural, enough potential. So the cells come from your bone marrow. And bone marrow cells, wherever you put them, they will adapt to the cells or adapt to the cells in that area and become those cells. For example, if you put a stem cell in the muscle, it becomes a myocyte. If you put it in the knee, it becomes a synoviocyte. So it's a pluripotential cell. So stem cell, so they have to harvest the stem cell from your bone marrow. So they can take it from your pelvis, your hip, that kind of painful still. But the good thing is now,
body is amazing.
They have stem cells that you can purchase. Synthetic. Yes, ma'am.
Just like here.
Like
you just go buy, but you know what?
Yes, like hair. I used to have
like synthetic hair.
I used to have tall hair, long hair.
Really?
Yeah, man. But my tall hair, I couldn't sleep with it, so I used to have the clipping one. So I go to bed with short hair and wake up with long hair.
And that's how I do a wig thing now. Baps
wig.
Off. Yeah, man.
You have a white wig?
Take off the wig. People have all kind of wigs.
I have a white wig.
You have a white wig.
I have a white wig.
I am not surprised you have a white wig.
I wore it to Dinion Blanc years ago.
That is fascinating stuff.
I'm going to put up my white wig picture on my Instagram.
I think you really should do that. I'd love to see it.
In a white frock with a white wig. I look like Storm.
Man.
From Avengers.
You would look. That would be so cool.
Anyway, where were we?
My God, I'm sorry. We don't talk about buying
stem cell.
Just like what you buy
here. Right. So you can actually purchase stem cell. How did we get there, guys? We are talking about medicine, not about hair. But we always have to keep medicine fun because sometimes them say doctor boring. And it can be quite boring. So this is how we entertain ourselves. So you remember, I know you will remember that stem cells, you can harvest it from your iliac crest or you can purchase it synthetically.
Yeah, man. You like from a store?
A pharmaceutical store.
Yeah, man, a store. That's a doctor's store, you know what I'm saying?
A doctor's store.
Great.
Right.
Pharmaceutical store.
So we can do stem cell injection as well. And so these are some of the things. Another thing, there are other injections that you can do that you do not put in anything, like dry needling.
Okay.
So
You're going to have to help me with that
Dry
one.
needling.
Dry needling.
All right, so we use very, very even ultra tinier, thinner needles, acupuncture needles. So this is not acupuncture. So we're not trained acupuncturists.
I don't like
So what we
those
do
needles.
is use acupuncture, but they're tiny, tiny, tiny. I
prefer the big needles and the tiny ones.
But sometimes you can't feel it when the tiny needles go in. I've had acupuncture done or dry needling, and they do a distraction method. In fact, I have a method that I tell my patients I call the Dawson method. So when I'm going to inject you, I have on my glove, it's sterile. I use my fingernail and I kind of stimulate. Like 3 years, I keep tapping your skin really hard. So when I'm finished, you actually have my fingernail print. But when I go in, you actually don't feel the needle. And the patients are like, are you serious? You're done? I'm like, yes, I'm done. It's called the Dawson's technique.
That's good. Can't trick me, do you know? Can't trick me.
You won't come for your injection?
I'm not interested in the injections,
What
dog.
you talking about?
Let me take me further up in the algorithm. I'm gonna reach injections, man.
Take it in the algorithm.
Number one step, man. Rehab. Let me start with rehab. Yeah, man. Lifestyle. I'm gonna reach injections.
Right.
I'm not the one.
Not the one, you never know.
Not today.
Well, not today. You know, I've injected myself.
Because you're a professional.
In my neck. I had knots in my neck. One night, I couldn't move. I just pull up some lidocaine and juke it in my neck.
Don't try this at home.
Do not try it at home. I also pierced my own navel.
You know what?
I did actually.
So because you can't do the injections, you just pierce your navel.
Actually, I numbed it with lidocaine first.
What's happening on this show?
All right, that is what we're talking about. Do not pierce your own navels, guys. It is not good because you can get infection. But I actually did do my own navel. And my friends were like, we had a piercing party. I did 3 piercing that night.
I'm really proud of you. Congratulations.
I
don't know how you did that.
We were silly. Yeah.
Come on. But I have a question. So there's a thing called an epidural.
Yes.
Steroid injection.
Yes.
But then also when women are having children,
yes,
there's an epidural. They call it an epidural, right? Is it the same thing?
Fantastic question.
Great stuff.
You know, because people always ask about that. All right, so when you're having baby, you do an epidural to block the lower body so you don't feel pain. Now, when you do an epidural, it's done at a higher epidural for labor, and that epidural is not just for labor. So if you're doing knee surgery or any surgery on the lower body, you can use half body anesthetic instead of general anesthesia, right? So they can actually, the anesthetists, they actually go at a different level, use different chemicals, and they go to a different layer in the spine. Whereas for pain management, which is what I do, they do it because they're so skilled, they do it without x-ray guidance. They know exactly where to go. And what to pull back because they have to get CSF fluid coming out to know they're in the right position. Where I go for pain, the epidural, we do it in a safe space. The anesthetists do it in a safe space too, but where we go, we monitor the flow on x-ray machine. And so all we block is pain. So when you're finished, in fact, you walk in and you walk out, right? And so a lot of times when we do the epidural steroid injection, patients go in with 10 out of 10 pain and they walk out with no pain.
Wow.
And so I've had patients who have been slated for surgery, you have severe back pain, shooting down your leg, and you should go through the algorithm, which is the rehab. It doesn't work. Then you do medication. That doesn't work. Then you do epidural steroid injection. There are different approaches. I do caudal, and I do transforaminal, which is caudal is in a safe area. You can use a larger volume. And I find that in our population, when I used to work in the States, we did a lot more what we call transforaminal from the side. But when I do caudal, I get good results. I don't know if it's because of the shape of our lower back, kind of deeper in curvature. I don't know. I should do a study like that. I should. Yeah. But I have had patients who can barely walk. I have patients who literally cannot walk. So with epidural steroid injection, the protocol is 1, 2, or 3 injections 1 or 2 weeks apart. And this is what International Spine Society and the North American Spine Society recommends, right? So we do 1. If you're 100% better, you do not need a second one.
Okay.
If we do 1 and you're 0% better, we do not do a second one because it will not help. Those are the patients that go to surgery, right? So there's a small percentage of patients it will not help. right? And then if we do one and you're halfway better, like 50% better or 20% better or even 60%,
Then they do the next one.
we do the next one. And why we do it? Imagine that you have a fire in the corner and you throw water on it. And you out the fire, but it's still simmering.
Yeah.
If you leave it, it can blaze up back. So we have to put another set of injection in there to quiet it down. And so lumbar epidural steroid injection, I mean, I have patients that are, my youngest patient was about early 20s, 22. My oldest patient was 97 years old. Wow. And those patients don't want surgery. They have back pain, they have sciatic pain, they want to come in. Now, don't get me wrong, there are patients that need surgery.
Yeah.
And those patients are the ones that, one, if you have rapid loss of function, bowel and bladder, loss of control, or pain, your quality of life just miserable, and no matter what you do, those are the patients that need surgery. But lumbar epidural steroid injections, I mean, the patients come in, they have severe pain. A lot of times I have patients that were told, you need surgery. I've treated international patients. I've patients actually have come to Jamaica to get yes, man, come true. We're international at the Rehabilitation
Institute of the Caribbean. You know.
We have patients that have come to Jamaica just for the epidural. Why? Because it's far cheaper. In Jamaica, in the States, it's 3 or 4 times more expensive.
I can only imagine.
Yes. 4 times or 5 times more expensive there than here. And it's the same. I mean, I worked in the States, so I know exactly what they do, right? And so patients do well.
Yeah.
They do well.
Good. Well, you know, Doc, a lot of persons are a little bit afraid of getting injection in their spine because they're afraid of paralysis.
I love that question. And you know, I like that question. Why? Because patients always ask that. No. So the good thing with lumbar epidural steroid injection, the literature, the incidence of paralysis from caudal, which is the technique I use, is 0. However, when you go higher up the spine, which is probably one of the reasons I don't do cervical spine anymore, because, you know, you have to be so super, super careful. I used to do it in the States. I just don't do it anymore. But the thoracic spine, where you actually have the spinal cord, the spinal cord ends at about your waist.
Okay.
Where we go is down by the natal cleft, which is kind of like the butt crack.
Yeah.
And that's where we go. And we'll watch the medication flow up to the area. And so the likelihood of paralysis is minimal.
Well, that's very comforting, actually.
It is. It certainly is. And even if we go higher, you know, you can go as far as just below the waist. Yeah. And we watch the flow.
Yeah. So it's not the needle that's going all the way.
No, it's the
just
flow. And then the thing is, when we're doing the transforminal ones, if we see the flow going towards the spinal cord, you just come out and reposition, because you don't want, it's not the needle that damages the spine, it's some of the medications that can do it, right? And so what we do is now we go in a safe space, and it's pretty safe. You know, patients, when I finish, they're like, you finished already? I'm like, yes. I've had patients, the blood pressure high. I just asked them. I always talk about KFC when at the table. I know, that's my comfort. And, you know, you ask the patients to relax. And when I finish, it takes me about 15 to 20 seconds fluoro time, x-ray time. So majority of the thing is about 15 minutes. You come in, steroid, but by the time I finish, break your skin and finish, it's less than a minute. Longest is about 5 minutes.
Thank you so much, Doc.
Yes.
And that's all the time we have. Thank you for joining us on Rehab Now. Thank you to our studio producers, Renee, Stacy, and Jeff, our studio engineers, Power 106. Thank you so very much. Rehabilitation Institute of the Caribbean. All right. God bless.
Bless you all.